Good morning everyone. Today we are going to talk about hypertensive retinopathy. Hypertensive retinopathy refers to fundus changes occurring in patients suffering from systemic hypertension, and according to WHO, systolic blood pressure more than 140 and diastolic blood pressure more than 90 is considered as hypertension, and hypertension can lead to retinopathy, choroidopathy and neuropathy, and retinopathy is the most common one. And now talking about the retinal vessels. Retinal vessels differs from other blood vessels because there is absence of sympathetic nerve supply, and retinal vessels have autoregulation of blood flow, and there is presence of blood retinal barrier. Talking about the pathogenesis, factors which play a role in pathogenesis of hypertensive retinopathy are vasospasm, arteriosclerotic changes, increased vascular permeability, and raised intraocular pressure. And now talking about the vasospasm. Due to vasospasm, there will be arterial narrowing, which is the primary response to raised blood pressure. And in young individuals, it occurs in pure form, while in elderly population, it is also affected by the pre-existing involutional sclerosis. And if there is vasospasm of choroidal blood vessels, then there will be narrowing of the arteries that may lead to the ischemia of choroid and retinal pigmentary epithelium that may lead to hypertensive choroidopathy. And if there is vasospasm of peripapillary choroid, then there will be ischemia of the optic head that may lead to the hypertensive optic neuropathy. And the next factor is arteriosclerotic changes, and due to the thickening of the vessel wall, it results in changes in arteriolar light reflex and AV nipping. Arteriolar light reflex or red reflex is nothing but a technique for clinical examination of retina and its blood vessels. In this technique, there is shining of light into the eyes and observing the reflection of light through the eyes. In normal healthy eye, when light is directed into the eye, it passes through the cornea and lens and reflects off the inner retina, especially from the blood vessels and mainly the choroidal vasculature. And it appears to be red in the normal healthy eye, and this red reflex signifies the transparency of the ocular medias and healthy blood vessels. But there is change in the arteriolar light reflex in the hypertensive retinopathy, and normally there is no AV nicking, but it is seen in hypertensive retinopathy when a small artery is crossing a small vein, resulting in the compression of the vein with bulging on either side of crossings. And the next factor is increased vascular permeability. As we all know, vascular permeability refers to the ability of the blood vessels to allow substances such as fluid and certain molecules to pass through their walls. Under normal circumstances, the blood vessels in the retina are tightly regulated to prevent excessive leakage of fluid and other components. But however, in the presence of chronic hypertension, several changes can occur that lead to the increased vascular permeability, like endothelial cell dysfunction and damage to special walls. And now talking about the hypoxia. Hypoxia refers to a condition when there is a deficiency of oxygen in the tissues, and when tissues including the blood vessels do not receive enough oxygen, it can trigger various physiological responses including the increased vascular permeability. So, hypoxia can also result the increased vascular permeability, and it can lead to the breakdown of inner blood retinal barrier that could be responsible for hemorrhages, exudates, focal retinal edema and macular edema. And the next factor is raised intraocular pressure. It is mostly seen in the malignant hypertension, and it manifests as hypertensive optic neuropathy, which is characterized by papillary edema and optic nerve ischemia. Now moving on to the classifications. First of all, Michel and Wong classification of hypertensive retinopathy. The severity of the hypertensive retinopathy has been graded into mild, moderate and malignant. And the severity helps in the prediction of risk of cerebrovascular diseases, coronary artery diseases and mortality. If there is no retinopathy, there is no detectable retinal signs and there is no any systemic associations. And if there is presence of one or more than one of the following arterial signs, like generalized arterial narrowing, focal arterial narrowing, AV nicking and arteriolar wall opacity, that is silver wiring, then it can fall under mild retinopathy. And in mild retinopathy, there is moderate association with stroke, subclinical stroke, coronary artery disease and mortality. And now talking about the moderate retinopathy, if there is presence of one or more than one of the following criteria like hemorrhages, blot and dot type or flame shaped, microaneurysms, cotton wool spots and hard exudates, then it can fall under moderate retinopathy and it has strong associations with systemic diseases. And now talking about the malignant retinopathy, there is presence of both features of moderate retinopathy and there is disc swelling also, and it has strong association with mortality. In modified C classifications, there is staging of retinopathy changes and there is grading of the light reflex changes resulting from arteriosclerosis. Now talking about the staging of retinopathy, there is grade 0, 1, 2, 3 and 4. And in grade 0, there is no changes. And in grade 1, there is barely detectable arterial narrowing. And in grade 2, there is obvious arterial narrowing with focal irregularities. And in grade 3, there is presence of grade 2 and there is also presence of retinal hemorrhages and exudates. And in grade 4, there is presence of all features of grade 3 and there is disc swelling as well. And now talking about the grading of the light reflex changes resulting from arteriosclerosis is as follows. In grade 0, it is normal, and in grade 1, there is broadening of the light reflex with minimal arteriovenous compression. And in grade 2, there is presence of light reflex changes and arteriovenous crossing changes are more prominent. And in grade 3, there is copper wire appearance and there is more prominent AB compression. And in grade 4, there is silver wire appearance and severe arteriovenous crossing changes. Copper wire appearance is the reddish-brown reflex of the arterioles due to the progressive sclerosis and hyalinization, whereas silver wire appearance is the opaque white reflex of arterioles due to continuous sclerosis. Now talking about the Keith and Wagner classifications, in grade 1 there is mild generalized arterial attenuation, particularly of the small branches with broadening of the arterial light reflex and vein concealment. And in grade 2, there is marked generalized narrowing and focal attenuation of the arterioles and associated with deflection of veins at AV crossing, that is also known as the Salus sign. And now talking about grade 3, the characteristics of grade 2 are present and there is also presence of copper wiring of arterioles, banking of the veins distal to the AB crossing, that is Bonnet sign, tapering of the veins on either side of the AB crossing, that is to the Gunn sign, and there is right angle deflection of the veins, that is Salus sign. And there is also presence of flame-shaped hemorrhages, cotton wool spots and hard exudates. And in grade 4, there is all features of grade 3 and also presence of silver wiring of arterioles and papilledema. Clinical features. Clinically, hypertensive fundus changes can be described as benign or chronic hypertensive retinopathy and malignant hypertensive retinopathy. Benign or chronic hypertensive retinopathy is of three types, that is chronic hypertension with involutionary sclerosis, chronic hypertension without sclerosis, and chronic hypertension with compensatory arteriolar sclerosis. Now talking about the chronic hypertension with involutionary sclerosis, when hypertension occurs in elderly patients, that is more than 50 years, in the presence of involutionary sclerosis, the fundus changes comprises augmented arteriosclerotic retinopathy. Talking about chronic hypertension without sclerosis, it is most commonly seen in the young people where the elastic retinal arteries are exposed to the raised blood pressure. In chronic hypertension with compensatory arterial sclerosis, it is most commonly seen in the young patients with prolonged benign hypertension, and it is usually associated with benign nephrosclerosis, and here the young arterioles respond by proliferative and fibrous changes in the media. So it is compensatory arteriolar sclerosis and it is also described as albuminuric or renal retinopathy. Now talking about the fundus changes of chronic hypertensive retinopathy, there is generalized arterial narrowing or attenuation, there is focal arterial narrowing, and there is arteriovenous nicking, which is the hallmark, and it occurs when arteriole crosses and compress the veins as vessels share the common adventitious sheath. It is also known as AB crossing changes, and this includes Salus sign, Bonnet sign and Ghosn sign. As we have already discussed, Salus sign is nothing but the deflection of the veins at AB crossings, and Bonnet sign is the banking of the veins distal to the AB crossing, and Ghosn sign is tapering of the veins on either side of the crossings. And there is presence of arteriolar reflex changes, and in grade 1 and 2 there is more diffuse and less bright reflex. In grade 3 there is presence of copper wiring. Copper wiring is reddish brown reflex of the arterioles due to the progressive sclerosis and hyalinizations. And in grade 4 there is silver wiring, which is the opaque white reflex of arterioles due to the continuous sclerosis. And there is also presence of superficial retinal hemorrhages on the posterior pole, which is flame-shaped, and there is also presence of hard exudates. Hard exudates are the lipid deposited in the outer plexiform layer of the retina in posterior pole and may be arranged as macular star. And there is also presence of cotton wool spots. Cotton wool spots are fluffy white lesions that represents areas of infarcts in nerve fiber layer. So these are the fundus changes. And moving on to the malignant or acute hypertensive retinopathy, it is a rapid progression of hypertension to a serious degree in a patient with relatively young arterioles undefended by the fibrosis. And the fundus changes are marked arterial narrowing, superficial retinal hemorrhages, that is a flame-shaped. There is focal intraretinal periarterial transuders along the major arterioles, and there is presence of cotton wool spots, which is more marked, and microaneurysms, shunt vessels and collaterals can also be developed. Now moving on to the management. In mild hypertensive retinopathy, it requires blood pressure control only. But in moderate hypertensive retinopathy, in addition to the blood pressure control, benefit from further assessment of vascular risk factors can also be done, for example cholesterol levels. And in accelerated hypertensive retinopathy, there is urgent hypertensive management, and small stepwise control of blood pressure over the few hours should be done, and there should be avoidance of sudden reduction in the blood pressure, because if there is sudden reduction in the blood pressure, then there will be reduction in the perfusion of optic disc and central nervous system that may lead to the stroke, and regular follow-up with ophthalmologist should be done.